Okay. Okay, now I see it. So I've just rejoined.
Okay, we can hear you now.
Great. I left the meeting and rejoined. I don't know why it did that. So if I... okay, I see my window. So I'll share this. Okay, do you see my presentation now?
Yes, just click the present button down on the bottom of your presentation, like of the computer screen. So it'll make it full screen and then you should be good. Oh, now it went away.
Okay. So do I present in a window or it should be entire screen?
So are you using a PowerPoint?
Yes.
Okay, so use a window,
okay.
And then at the bottom of your screen, once you open that window, you'll need to click the little present button.
And I don't know.
It looks like a little rectangle on top of a stand.
Okay. So weird. I didn't see it at all.
That looks good, Helen. But maybe if you then press start slideshow and just see if that works.
I go back. Maybe if I go back into the window.
That looks good.
There we go. Now you're good.
Oh, okay. I can't see you, but maybe that's a good thing. Okay. Right. Shall I start then?
Yes, go ahead.
Okay. So thank you everyone for coming. Sorry about the technical difficulties. I did actually watch a little Google tutorial on this, but obviously it didn't work. But anyway, so I picked this paper today on AKI in dogs with septic peritonitis. I think it's a fairly straightforward study, but really because I'm interested in the topic and also just the difficulty of studying this area. So, you know, starting with a little bit of background in people, you know, sepsis is the most common cause of AKI in the critically ill. And it's kind of amazing how common it is, but how little is still known. And I think the other thing that's interesting is its kind of unique pathophysiology. So initially it was thought, as in this paper, and it would make sense that a patient who's in shock would have ischemic injury and would develop acute tubular necrosis, and that was initially thought to be the cause of septic AKI. But actually, it was then found there were some inconsistencies. So some of it is that you don't even have to have hemodynamic instability to develop an AKI from sepsis. And a lot of experimental models, they found that you could have even increased renal blood flow and still develop an AKI. And then the other thing that doesn't match up would be that you could have a patient with very severe decrease in kidney function, but the actual histopathologic changes were just surprisingly mild and very, very minimal necrosis often found. And so the updated theory, kind of this unified theory, encompasses three major mechanisms. So inflammation, microcirculatory dysfunction, and metabolic reprogramming. So the first thing being inflammation. I think we're all very familiar with how sepsis, we get the release of PAMPs and DAMPs, and they will bind to pattern recognition receptors, and then we get this whole inflammatory cascade. And the poor old tubular epithelial cells are really under a double attack. So not only do they see all of these DAMPs and PAMPs and cytokines and other inflammatory mediators through the bloodstream via the peritubular capillaries, but also they get filtered through the glomerulus, so they're exposed to them via the tubular lumen as well. And renal tubular epithelial cells express their own pattern recognition receptors, so they can also join in. They have a lot of particularly toll-like receptor 2 and 4, so they will synthesize and release their own cytokines and their own reactive oxygen species, and they may even start talking to each other, so they initiate some paracrine signaling. Plus all the white blood cells that infiltrate the renal interstitium as well. And the second aspect is the microcirculatory dysfunction that happens all over the body in sepsis, but certainly some profound changes in blood flow through the kidneys. And so one thing that happens, there's vasoconstriction of the afferent arteriole, and as the epithelial cells start to do less of their job and taking up sodium, and there's activation of tubular glomerular feedback, and that compounds this constriction of the afferent arteriole. There's also dilation of the efferent arteriole, and a lot of the time these shunts open up, so sometimes the glomerular blood vessels get bypassed altogether. And then, as well as this is happening all over the body, but vasodilation, endothelial leak. And so that's allowing white blood cells to leave the circulation and get to the site of infection. But at the same time, all of that interstitial edema means that it's harder and harder to get oxygen to the epithelial cells. Plus, white blood cells, all this blood flow is getting sluggish and they're leaving the circulation, but platelets are also attaching to the vessels. There's activation of coagulation, so a lot of microthrombi formation. And overall, this causes a decrease in GFR and renal function. And some of this may actually be a protective mechanism. So the less GFR there is, the less exposure there is for these tubular epithelial cells to inflammatory mediators and oxidative damage. But of course, for renal function, it's definitely a bad thing. And this diagram I found in a really nice review article from Kidney International, and it's just showing those changes in blood flow, showing all the damps and pamps heading into the tubular lumen, and then a little bit of a close-up on a peritubular capillary, just showing how it's losing all of its glycocalyx, and there's vasodilation, the flow is slowing down, there's interstitial edema, and all the neutrophils that are leaving the circulation. And then the third thing is metabolic reprogramming. So the cell really prioritizes its own survival. And so this is why it's thought there's not actually that much necrosis. The cells don't die, they just go on a little bit of a vacation. So they stop producing what they consider non-vital functions. So they stop producing, receptors, ion channels, various transporters, and they limit their functions only to production of what they really need. So things like sodium potassium ATPase pumps, they decrease their mitochondria, so they use less energy, there's less reactive oxygen species being formed, less oxidative stress, less chance of damage to the cell. And then you really go into a kind of hibernation and a cell cycle arrest. And even their substrate utilization can become altered. So they start decreasing oxidative phosphorylation, they move into aerobic glycolysis only, almost like the Warburg metabolism seen in cancer cells. And they also become less responsive to pro-apoptotic signals. So overall, the cells are surviving, but they're just not doing their job. And so I just found a few kind of sobering statistics on septic AKI in people. So it's thought that up to 60% of people with sepsis either have or will develop an AKI. But if you flip that around 50% of AKI in people in ICU is caused by sepsis. People with septic AKI have a significantly higher mortality than both those without AKI, but also people who have AKI of any other cause as well. And they may recover from AKI, it's possible, but it's very common that they will relapse. And so if they don't recover, there's also a pretty high mortality rate. And so, sorry, this is a horrible slide. I was just trying to fit everything in that I could find, just as a little bit of background in the literature. But in terms of preventing septic AKI in people, it's really an emphasis on, good management of sepsis. So the things we already know, so early antimicrobials, source control, enough fluids, but without too much, and switching to pressors where needed. If they are becoming fluid unresponsive, prioritizing norepi, maybe and/or vasopressin, avoiding dopamine, phenylephrine. Some promise with angiotensin too, so that's licensed now as a second-line pressor in septic people, well, not just septic, but catecholamine-resistant vasodilatory shock. And there was an AKI subgroup in the ATHOS-3 trial who required less renal replacement therapy, so that could be a future avenue. And then just a couple of other points, which I think are getting a little bit off topic, but I found interesting. And in terms of treatment, not a huge amount of direct treatment, but just really closely monitoring these patients and picking up early signs of AKI as soon as possible, doing no harm. So avoiding nephrotoxic drugs, avoiding too much chloride in fluid therapy. So a balanced crystalloid is probably preferable. Hydroxyethyl starch, of course, a black box warning in septic people. I think we don't know as much with our patients. And avoiding hyperglycemia. So in this consensus report for sepsis-associated AKI, it's recommended to avoid a blood glucose greater than 150 mg per deciliter for more than 3 hours. It's certainly pro-inflammatory and can promote oxidative damage and all sorts of adverse effects, osmotic diuresis, all sorts of things that we benefit not allowing that to be prolonged. Timing of RRT, it seems that probably not much different to other causes of AKI. Avoiding prophylactic diuretics, but if they're used to retain optimal fluid balance, then that's okay. And just a couple of other drugs that have been proposed that often perform well in experimental studies or early trials, and then often don't translate quite as well to the larger clinical trials, but just some possibilities for, whether we target apoptosis or inflammation or mitochondria, so just some, or hemodynamics, so different sort of drug classes that could be promising. And in terms of recovery from septic AKI, it's certainly possible, but there is a high rate of relapse, even in patients who do recover. And then the other thing is that if they don't completely recover after 7 days, they enter this new kind of interim phase between AKI and CKD of acute kidney disease. And it's very much recommended these patients do have long-term follow-up with a nephrologist, whether they've recovered or not. And this is another diagram just from that article in Kidney International, that review article, that just shows all of the kind of consequences and interrelations of recovery, versus relapse, versus acute kidney disease, CKD, and just that this is all very depressing for people with septic AKI. And so what do we know about this entity in dogs and cats? And I found this review article in DACVECC, which is really nice. It's kind of cool because it's written by a veterinary criticalist, but also a human nephrologist, and he's quite widely published in the area of septic AKI. So it's really interesting. It's kind of an amalgamation of everything that was known at this time in human septic AKI and what little is known in our veterinary patients. And I was looking at this thinking, 2015, it's not that long ago, but then it's actually nearly 10 years old. So maybe time for an update, but it's still a good read. And so it really brings us to the paper that I chose for today. And so this isn't strictly just septic AKI, but this is really looking at dogs with septic peritonitis and acute kidney injury and looking at mortality. And so in terms of the background, they introduce a topic with some information about what's known in human medicine, and they bring up two main papers that we have in our small animal patients. One is a retrospective review by a study by Kenny et al. 2010 from JAVMA. And they looked at 114 dogs with septic peritonitis. And amongst those dogs, they reported that around 12% developed renal dysfunction. And that was categorized at that time by an increase in creatinine of at least 0.5 mg per deciliter during the hospital stay. And only 2 of those 14 dogs who developed renal dysfunction survived to discharge. They also quote a paper from GFMS, so Troyer et al. 2018, and that looked at 43 cats with sepsis, and these were multiple causes, so they didn't have to just be septic peritonitis. They could have pyothorax, pyelonephritis, and also septic peritonitis. And they reported that around a third of those cats presented with azotemia, and then 18 of the 43 cats developed a new onset azotemia as well. And they reported an odds of 4.7 mortality in septic cats with AKI versus those without. And then they go on to talk a little bit about the pathophysiology of sepsis-associated AKI, which we've already talked about. And it got me just having a little bit of a literature review on this, just thinking, what else do we know? I mean, there's so many experimental models reported in human medicine, and you'd think that some of those would be on dogs potentially. And I found this paper on AKI in pyometra, looking at different biomarkers and ultrasound variables. There's a fairly recent 2023 endotoxin model in beagles where they literally inject endotoxin intravenously. And 3 of those 6 dogs developed AKI, and they really used a number of sort of biomarkers to trend their development of AKI. And they found that serum creatinine did increase, but perhaps not surprisingly, it took more time than the others. So it took around 48 hours to see an increase. And then this third paper at the bottom is out of RVC from 2015. And this was looking at dogs with sepsis undergoing emergency laparotomy. And this was a prospective case control study, and they followed serum NGAL and urine NGAL as well. And they excluded all patients with presenting azotemia or CKD. And they found something that's also been mentioned in human medicine, and perhaps not surprisingly, that serum NGAL is already increased in septic patients, and so they felt that was less useful. This is also reported in human literature, but perhaps you just need a higher cutoff. But that's just something to bear in mind that's specific to sepsis. And so really getting back to the paper and the remainder of the introduction, they go on with a little bit more background. They start to focus on perioperative risk factors for AKI. And they list 5 papers, and 3 of those are from people. One of them is a veterinary retrospective study. This was all forms of AKI, looking at etiology and looking at how they kind of progressed during hospitalization. They don't really focus on sepsis or any kind of surgery. They do mention that 22% of the hospital-acquired AKI patients developed that post-anesthesia. And they also categorized septic peritonitis with other inflammatory causes. So there was all sorts in there, so pancreatitis, heat stroke, gastroenteritis. So it wasn't really focused on surgery or anesthesia at all either. And then a veterinary review article on AKI, and that doesn't really mention surgery or sepsis. They then go on to outline septic peritonitis in dogs. So they report it, of course, depending where you look, but anywhere between a 29 to 85% mortality rate in dogs with septic peritonitis. And then they make the comment that dogs surgically treated for septic peritonitis require intense post-operative care, extended hospitalization, and high costs of care. And AKI exacerbates all of these concerns. So I think that's probably very true, hard to argue with that. And in terms of the kind of knowledge gap for this study and the justification of why the veterinary literature needs it, I don't really specifically go into that, but I think it's, you know, clear that the literature on this topic is very limited. We do have that Kenny et al. Study, but that was 2010. And certainly we have our RSAKI grading system now. They really want to focus on looking at risk factors and what's the impact of specific kidney-related risk factors on survival to discharge. So I think, you know, all of these things we definitely do need to know more about. So I think certainly justification for the study. In terms of objectives, the primary objective was to determine the frequency of AKI in dogs undergoing abdominal surgery for septic peritonitis. Secondary outcomes were survival in dogs with AKI versus those without, to try to identify risk factors for AKI, and to try to assess the relationship between AKI grade and survival to discharge. And they expect that the mortality rate for dogs with AKI will be higher than dogs without. And they list a number of risk factors they expect will, you know, promote AKI. And also that higher AKI grades are likely to be associated with higher mortality rates. And that's certainly been reported in other veterinary papers. So I think, you know, very reasonable. In terms of study design, it's a fairly straightforward study design. It's really a you know, retrospective observational study with a search of the electronic medical record database over a 10-year period, weeding out all the patients, all the dogs with septic peritonitis. There's not really any particular exclusion criteria, but in terms of inclusion, and they had to have undergone surgical intervention for septic peritonitis, and they list the ways in which this could be diagnosed. They divided up the causes of septic peritonitis into 4 categories, so gastrointestinal, urogenital, other, and unknown. The dogs all had to have had at least 1 blood creatinine measurement pre-surgery and 1 post. The timing of that was very variable, but they had to have those 2 measurements to be included. And they also went into some detail about the analyzer they used. The creatinine was all measured on a single analyzer, and the upkeep. And they also mentioned a minimum follow-up time, 6 months post-discharge. This didn't mean that every single patient was followed up for that long. It was just the patients where they did have follow-up information available, that minimum time was 6 months. And in terms of classification and grading systems, I think we're all familiar with the SIRS criteria, and they used an APPLE-FAST score on patients where possible, and they defined hypotension, whether that was intraoperative or postoperative. And in terms of their diagnosis of AKI and how they made that diagnosis, they utilized RSAKI criteria. Or there was a comment, evidence of rapid decrease in GFR. So I don't know if, I mean, I think all of them had an RSAKI grade applied. I don't know if they meant by this that this, you know, grading, maybe they were increasing grade and that indicated evidence of rapid decrease in GFR. In terms of baseline, I think with many studies, if you don't have a baseline creatinine for patients, it makes it very, very difficult. So they chose to use their first creatinine measurement as their baseline. They didn't have any urine output data available, and they don't have extracorporeal therapy available. And then I had to remind myself about the APPLE-FAST score, and certainly the APPLE score, the acute patient physiologic and laboratory evaluation, really an illness severity score for dogs. The full score has 10 variables, the FAST one only has 5, so I've put that in a table at the bottom. And this was derived from a population of dogs in ICU, 810 dogs. And I guess one thing is, you know, trying to determine quite how sick they were. In this population, any dog that required IV fluids gets admitted to the ICU. But the score has been validated not only by these authors, but there are some other studies looking at the APPLE score, and it seemed to perform quite well in a different population. So the paper I've put at the top there was a applying it to dogs admitted through the emergency room in a different institution, and it performed quite well. And so when it comes to the AppleFast score, the maximum score is 50, and a score over 25 has been associated with increased mortality. In terms of how septic AKI is diagnosed in people, there's no actual single definition. And the other thing is sometimes you see sepsis-associated AKI reported, sometimes sepsis-induced. And sepsis-induced strictly is a subphenotype of the sepsis-associated, so it gets quite complicated. But really, it seems to be accepted that it's defined as AKI in the presence of sepsis without other significant contributing factors, or more objectively, the simultaneous presence within a 7-day period of both sepsis 3 and KDIGO criteria. And so just in terms of the sepsis 3 definition that's used in people, in 2016, they moved to this new definition where sepsis is a life-threatening syndrome characterized by organ dysfunction and really caused by the host's dysregulated response to infection. And certainly septic shock is a sort of subcategory of that with a pretty high mortality rate. And in veterinary medicine, we use the SIRS criteria, so a little bit analogous to the sepsis 2 definition. So for dogs, at least 2 of 4 SIRS criteria. And there has been criticism that it is non-specific when we use the SIRS criteria, and they seem to sort of poorly predict outcome and really focus on inflammation rather than that dysregulated host response. Having said that, there's also criticism of sepsis 3 in that it's less sensitive. So I think, but certainly this is our current definition in dogs at least. And then just looking at the evolution of grading criteria for AKI in people, certainly a move away from reliance on GFR to the most recent KDIGO guidelines, where we're much more focused on, small changes in serum creatinine. And so in terms of results of this paper, they reported 77 episodes of septic peritonitis in 75 dogs. So 2 of the dogs had 2 episodes of septic peritonitis. They report a signalment. In terms of etiologies, the majority were gastrointestinal in origin, and in around 1/5 of them urogenital. 50 dogs received pressors intraoperatively, and 26 dogs post-op. It's hard to tell for how long the post-op ones are. They looked at a 48-hour period. So did these dogs just need it for a short time following recovery? Or were they, septic shock patients that are needing pressors? It's hard to really know from the paper, but these were the figures that they gave. In terms of the diagnoses of AKI, they documented 40% of the dogs had an AKI at presentation or post-operatively, so 31 of 77 dogs. 18 of those presented with AKI, and then 13 of them developed it post-operatively. They didn't report any volume response of AKI at all, but they do make the comment that of 7 dogs with urinalysis results available, 3 of those had a suspected pre-renal azotemia. So I'm not sure, whether that ended up resolving and where they were counted. One dog had pre-existing CKD, but the azotemia was stable throughout. And they do also make the comment that 27 dogs underwent an abdominal ultrasound, and 3 of those had ultrasonographic evidence of CKD. In terms of risk factors for presenting with AKI, they found 3 major factors. So respiratory rate, so 53 breaths per minute in the AKI dogs versus 37 in those without. I think it's difficult to know because for me, if they're presenting with this, it's just difficult to know which has come first. So can we truly say this is a risk factor, or is it a consequence of the AKI? Is it just that they've happened to present together, or they're sicker patients? The other finding they had was systolic blood pressure. So a lower systolic blood pressure was more likely in the dogs presenting with AKI, so 99 versus 132. And also a higher body condition score, so 6.3 versus 4.6 in dogs with AKI. And they found some risk factors were significant when they did their multivariable analysis, and they were looking for risk factors for dogs developing AKI postoperatively, but none of those remained significant following adjustment. This is all the factors that they looked at that were not associated with postoperative AKI. And in terms of kidney-related risk factors for survival to discharge, they report that 20% of patients overall did not survive to discharge, and 3/4 of those had an AKI, and around 1/4 did not have an AKI. And they do report that the mortality was certainly much higher in dogs with AKI, so an 80% decreased odds, and I have to remember this is odds, not an actual risk ratio, but decreased odds of survival to discharge in dogs with AKI. But looking at the cause of death, I mean, the vast majority were euthanasia, and they sort of say, you know, due to concern for their poor prognosis or financial reasons. And it's, I think, difficult with euthanasia just to tease out, you know, what was the actual reason for euthanasia? Were these dogs sort of declining very rapidly and they were going to die anyway? Is it that we recognize that AKI is a serious complication in these patients, and so our bias is to say, well, this is a poor outlook and owners euthanize for that reason? Is it because we predict they have a longer stay in the hospital and so they euthanize for financial reasons? I think it's hard to tease out that from the paper. And they also found for every 0.1 mg per deciliter increase in initial blood creatinine postoperatively, odds of survival to discharge decreased by 40%, so an odds ratio of 0.6. And then findings that were not associated with survival to discharge, so the highest preoperative AKI grade, the highest AKI grade 1 day post-surgery, and the highest overall AKI grade. None of those were associated with survival. And this is just a table that they showed in the paper, just giving you an idea of the timing of AKI and the grades of AKI as well. So the majority being either preoperative or a day post-surgery, anywhere between sort of grades 1 to 4. And in terms of long-term outcome, 50% or just over 50% of these dogs were followed up in the longer term. And around 1/3 of those were in the AKI group, so 10 of 32 dogs, and 2 of those developed CKD. And then around 2/3 were in the non-AKI group, and 3 of those dogs developed CKD, although 1 had CKD preoperatively, so I'm not sure that counts. And in terms of the discussion, so, you know, again, they report their major results. So AKI documented in 40% of dogs with septic peritonitis undergoing surgery, and certainly an increased mortality in those dogs with AKI. They then go on to talk about these sort of findings that they had of hypotension, the unadjusted p-values being significant. So intra and post-operative blood pressure was significantly different in the dogs with AKI pre-adjustment, but then post-adjustment lost significance. And so they sort of talk about how it's like this kind of almost significance. They start speculating that, you know, maybe that is a true finding. You know, perhaps these dogs have a high mortality because they have hypoperfusion, ischemic injury, acute tubular necrosis. They also discuss the findings of increased respiratory rate and decreased systolic blood pressure on presentation associated with dogs presenting with AKI. And they kind of make the comment that maybe that was due to septic shock. I think that's probably a little bit of a stretch, and it also would have been something, I mean, it has a clear definition. I think that would have been something you could prove or disprove. I do think this finding of increased respiratory rate on presentation being associated with AKI is something that has been reported in previous veterinary studies, and the authors in those studies have commented, perhaps it's due to inflammation and pneumonitis, or perhaps these patients have pulmonary edema because they're already fluid overloaded. So, I mean, that definitely seems to be a consistent finding. And they also talk about the association of increased body condition score being associated with presenting AKI. And they talk about the human data. It's very controversial in people. I did a sort of quick look, and maybe partially a confounder, because it's been found in a lot of retrospective studies, and some of the authors think that a lot of people with obesity end up in the ICU. A lot of ICU patients end up with AKI. Perhaps it's also to do with malnutrition, so protein content in the diet. So I mean, that's certainly a finding from this study, but it's hard to tease out quite why that might be. And they also comment small transient increases in creatinine may have serious consequences. In terms of limitations, I think they do a good job acknowledging these limitations. I think certainly any retrospective study, you're at the mercy of what's included in the medical record. There's no way of standardizing the data, and you will have missing data as well. I think one of the difficulties is once you start dividing this number of patients into subgroups, that some of those subgroups end up just very small, and it's hard to really do statistics on those. Plus, there's a lot of different variables they've tested, and we know, every 20 variables you test is going to be a significant value that's found just by chance. So that's also tricky, I think, when you have a relatively small group of patients. And they suffer, as do many human studies, from a lack of baseline data, so knowing just where they start. So things like baseline creatinine, it's very, very difficult if you don't have that data to know how best to diagnose, particularly the presenting AKI. And there's no information on urine output or hydration status. They make the comment themselves that the monitoring of creatinine was inconsistent, and perhaps the ones they were more worried about, they monitored more closely. So it's possible, some of these patients were misclassified, and really they were unable to evaluate long-term kidney function. And like I said before, it just had me wondering, why were the AKI dogs euthanized? And also just some of the difficulties in studying septic AKI. It's kind of interesting, I was reading as well in human papers that, because of poor muscle perfusion and other factors, so things like all the fluid therapy these patients receive, diluting the creatinine, often the creatinine production actually falls in these patients. So around 50% has been quoted. So that's kind of interesting that creatinine may actually be a little bit unreliable in septic patients, the lack of baseline data, the fact that even the same stage of AKI between two individuals, they can have very, very different outcomes. And so I think, the thing is, sepsis is such a heterogeneous condition. It's just very, very difficult to make comparisons between all of these different patients that hold true when you get another population of septic patients. A lot of independent risk factors that AKI patients and septic patients will commonly suffer. And then looking to the future and further refinement of AKI detection, so looking at emerging biomarkers, certainly in sepsis, so urine markers of cell cycle arrest, I think are interesting, and certainly, we saw all those tubular epithelial cells go into the cell cycle arrest, and so that seems to correlate with their risk of AKI, and all of this is really trying to pick up this population, not just of these sort of pre-renal azotemia patients, but the subclinical AKI. So they have suffered some kidney damage, but there's no loss of function and no change in creatinine or urine output. And so lots of possibilities for the future of how we may be able to pick up on AKI a little bit quicker and at an earlier stage and before there's been loss of function. And so in conclusion from this paper, they report overall mortality rate in dogs with septic peritonitis is lower than in other reports, but those patients that develop AKI, that has a significant outcome impact. And even non-azotemic increases in creatinine are significant, but I'm definitely preaching to the converted on that one. And it just got me thinking about some questions I had for maybe future research in veterinary septic AKI. You know, just how do we best define or subcategorize sepsis and AKI? How do we identify it at its earliest? Are there, you know, better protocols we can have to try and prevent it or treat it when it's developed? What biomarkers can we use? I guess a whole other topic would be the role of extracorporeal therapies in sepsis, and whether we should adopt the sort of paradigms of acute kidney disease and sepsis 3. And that was all I had. So very happy to have anyone's thoughts and questions. I'm going to end this show because I can't see anyone. There we go. Right.
It looks like Dr. Wilkes has raised her hand. You can go ahead, Dr. Wilkes, if you'd like. Oh, okay. No question. Well, if nobody else has any questions, thank you very much, Dr. Philp. We really appreciate you doing this.
We got there in the end.
Yes. No, it was great. Thank you so much.
All right. See you later, everyone.
Great job, Helen.
Can't say it. Well, I don't know. That Google tutorial didn't work, did it? But it's like.
No, it's great.
Okay. Oh, thank you.